Yeah.
Is that on enough?
No.
Right there?
Just give this a second.
How are you? Is your mom here? Yeah. Good.
Can you hear me okay back there?
Yeah.
Okay. Some of you in the back may want to move closer. You may have trouble reading the screen, but of course you also have copies of these slides, so reading the screen may not be that important to you. My name's Lynn Breedlove. I'm the co-chair of Wisconsin Long-Term Care Coalition. And Lisa Pugh, my colleague here, is the executive director of the ARC in Wisconsin. So we're going to be doing this training together tonight. And what I'd like to do is, obviously this doesn't exactly work for the people who are connecting remotely, but for the people who are here, you see that wall chart up there? What I'd like you to do very briefly is just tell us those four things: your name, what town you live in, whether or not you're a Partners in Policymaking grad, because I want people from one class of partners to notice their fellow partners grads who are in other classes, because some of you guys may not have met each other. And then also, if you know your member of Congress, it would be useful right off the bat to let us know. And also, if you don't know, this will give us a little time to figure out before 7:15 or 7:30 when we start talking about strategy in each congressional district. We'll figure out who your congressional representative is. So how about we start in the front row? Go ahead.
Maria, I'm from Milwaukee. I think I'm a partner's candidate. And my member of Congress is Wedmore.
I'm Melissa. I'm from Blake. I'm from Partners Class 1, and my member of Congress is Rep. Okaya.
My name is Julie from Milwaukee, South Side. I am a partner grad, 11 years old. And my parents David.
What did you say, Neely?
I think she mentioned her state legislator, so is it possibly Gwen Moore for Congress?
In Milwaukee, probably.
She said, you said Southside?
Yeah. 43rd and Lincoln. Miller Parkway.
Oh, yeah.
Would she be Gwen Moore? Okay.
Yeah.
All right.
Okay, we'll just keep moving back this side then. Go ahead.
Hi, Prashant Olson, Milwaukee. I'm a current partner and I'm represented by Gwen Moore.
I'm Charlie Bergstrom. I'm also from Milwaukee, live in Whitefish Bay. I'm not a partners grad at Whitmore.
I'm Teresa Barnes, Milwaukee. I am in the Partners Program now for the training, and Wedmore is my member.
I'm Meg Stanley in Cincinnati, and I'm in Wauwatosa. I am a Partners grad from where we said we were creating. And I'm 2 cents.
I'm Catherine. I am from Wauwatosa also. I'm not a Partners grad, and
Sensenbrenner?
yeah.
Okay, thanks.
I'm Shay, I'm from Milwaukee, no, I'm not a partner, and Whitmore.
I'm Meredith. from Kenosha. I'm a partner grad in 2015, I believe, and I am in Paul Ryan's district. I'm Nancy Gupinski. I'm from Glendale, and I'm a partner's grad and one more.
I'm Julie Brush. I'm from Brookfield. I am a partner's grad, P3, and sense of learner.
I'm Emily from Milwaukee. I am a partner's grad, 4th class, and don't know.
Gwenmore, did you say?
I'm Lori Fatla. I'm in Milwaukee. I'm Emily's mother. I'm partner's grad 1. And Glenmore.
I am Chip Meester. I am from West Dallas. I believe I was in partners ended in the spring of 2013. And then my congressperson is one more.
I'm Mike Heinberg. I'm from Milwaukee. I'm not a partner's grad. And my congressperson is Glenn Moore.
Okay, great, thanks.
Oh, and
Sally, go ahead.
I'm Sally Flashberger. I am from Waukesha. I am a partner's grad, and Sensenbrenner is my
can we get any information from people online? Can they type in or not?
I can't.
How many people do we have online?
I don't know.
Okay, so.
I have to go out of the screen to see that, so this is the
Thanks.
best I can do.
Thanks to Sally and Nancy Gopinski and Julie Burush and Marion Holberg, who's not here, for helping organize this event. We appreciate it. In January, we started to realize that Medicaid block grants were coming, and we realized we better not wait until they were formally proposed to Congress. We better get out in front of that. The Long-Term Care Coalition, Lisa and I are both part of that. We formed a Medicaid block grant work group. Lisa and I are both on it, and started looking at the information that was coming to us from the national level. Also, several organizations like Disability Rights Wisconsin, the Board for Persons with Developmental Disabilities, Save Iris, ARC Wisconsin, all started gearing up, sending information out to members and people at the grassroots level. Lisa now, because she's the executive director of ARC Wisconsin, is starting to get a lot of good information from her national office. The National ARC has a pretty strong public policy team. So that's been helpful. And as we saw this information coming in, we started to realize how big this danger was for people with disabilities. We were all very concerned about family care and IRIS 2.0, and there was a really good fight in the last couple of years to fend that off, but we realized this is actually a bigger fight. There's more at stake here. We're talking about the existence of the Medicaid program. Is it going to survive in a form that we're going to recognize here? So we realized we needed to do more than just send out action alerts and send you links to what we're getting from the national level. So Lisa and I decided we would put together a training, and since stuff's been coming in, almost every day the last couple of weeks, even this weekend, we were adding stuff to this, and I'm sure we'll keep revising it after this. So this is basically oh, you're past it now. Yeah, so it's a joint project of our two, the coalition and the ARC Wisconsin. Lisa and I did it together, and of course we got information from a lot of different sources that we put into this. And we also realized that we couldn't just make this about block grants. The more we started looking at what was happening with the Affordable Care Act, which some of you may think of as Obamacare, and the implications of that, we realized, well, that spills over on Medicaid, and we also started realizing there's another threat to Medicaid other than block grants, and that threat's called per capita caps, which we're going to explain. And so we then realized, well, we really need to cover all three of those in the training. So we're going to try to march through this pretty fast. If we're saying something that's totally confusing, raise your hand, we'll try to correct it then. But after we get through explaining to you what the issues are, before we get into advocacy strategy and action plans, we'll stop again then and see if you've got any questions and answers. So you'll have a chance at that point as well. So obviously a lot of people think, uh-oh, you know, the president wants this, leaders of Congress want this, the new Secretary of Health and Human Services wants this. You know, how could we possibly stop that? Well, that's what they told us when Governor Walker came out with his Family Care and Iris 2.0 proposal. People said, no way you can stop that. You know, Republican-controlled legislature, Republican governor, why even bother? Well, we decided we had to fight that fight anyway, because what was being proposed was bad. And we discovered as we got into it that we were actually able to convince members of both parties that there was something to be concerned about. And ultimately, when 2.0 was stopped, it was essentially a bipartisan decision of the legislature, we're not going to do this. So we feel that that's possible here. We feel that Republicans in Congress as well as Democrats could realize why this would be bad and eventually could be persuaded to vote against it. The other thing is the public is coming our way. And two recent Kaiser Foundation polls are very encouraging. The first one is that for the first time in years, more people think the Affordable Care Act is a good idea than think it's a bad idea. The other thing that this poll came out just last week, a poll on Medicaid. You know, should we block grant Medicaid? Should we overhaul Medicaid? 65% of the American people said no. We should have a strong Medicaid program with federal entitlements, federal standards, certain required benefits, and federal matching funds. So if those trends continue, that's going to help us. And one of the things we discovered with 2.0 is the longer the time went by before it was implemented, the more opportunity we had to convince decision makers that this was not such a good idea. So we're hoping we can do the same thing here. So we split this up. Lisa's going to talk about the Affordable Care Act now. Then I'll come back and talk about Medicaid. And then at the end, Lisa will lead the discussion of advocacy strategy too.
This is really high tech.
It's not ours. We borrow it. It's not.
I'll figure it out.
You want some help?
Actually, that sounds really good.
Somebody just hung up.
Oh, no. All right.
I'm trying to see if
Good
it's
evening,
working.
everybody. Okay, I'm Lisa Pugh, and thanks for being concerned about this issue and wanting to learn more. So I'm going to walk through the changes in the Affordable Care Act and kind of let you know why that's intertwined with the whole changes to Medicaid. How many people in the room use Medicaid in some way or have a loved one in your family that uses Medicaid? Okay, so that's our commonality here. So, and we'll talk about how the Affordable Care Act kind of ties into this. So, Sally, can you forward that slide for me? Okay, so here's kind of an overview of what's going on. If you've been watching the news and all, you hear this terminology about repeal and replace. A lot of the Republicans in the Congress ran in the election saying that they were wanting to repeal Obamacare, okay? And there's some discussion now of there's a lot of political pressure to say you have to replace it at the same time. So that's really the discussion that literally is happening in Washington right now. There are governors in Washington meeting with President Trump, I believe today, that are talking a lot about this, okay? The reason why it's connected to the Affordable Care Act is connected to these other changes in Medicaid is because they're proposing that they need to pay for the changes that they're going to make to Obamacare, and because they want to keep parts of it, they're going to pay for it by making big changes to all of Medicaid. So they need the math to work. They need it to be balanced so it doesn't cost too much. So they're going to take some cuts out of the big programs of Medicaid that have nothing to do with Obamacare and use that to pay for the changes that they're making in the Affordable Care Act. As Lynn mentioned, the details and the timelines are constantly changing. I actually saw a leaked bill from Congress that came through on Friday and spent the weekend reviewing that. And today I saw leaked information from the Republican Governors Association and some of the things that the governors want to see happen here. So there's a lot of political negotiation happening in Washington around this issue. And again, it changes every day. There are also different bills that are floating in Congress right now. And so the one that leaked on Friday is seen to be kind of the blueprint of where the House Republicans likely want to move. So that's kind of seen as the piece of legislation that we should be looking at. And so a lot of what Lynn and I talk about tonight will kind of be based upon that. Again, knowing that it could possibly change. It's unclear if the Senate will agree with the House. So in Senate, you have some more moderate voices of people that are very concerned about big changes to Medicaid. So once the House is done with their proposal, obviously it needs to pass in the Senate. So this will be a process that requires a lot of negotiation. But I think the one thing that's clear for us is that if this fight is lost at the federal level, a lot of healthcare unravels, not just for people in the Affordable Care Act using the exchanges, but for people who use all of Medicaid programs. And Lynn will talk about kind of the different programs in Wisconsin that are funded through Medicaid. But that's why we're here tonight, to figure out what our job is. Okay, so you see that I say, in my slides, I say ACA/Obamacare. Obviously, Obamacare is a very politically charged issue. A lot of people refer to it as Obamacare, but some people don't even realize that they're getting health care in the exchanges for the Affordable Care Act because they don't see the two as the same. But the Affordable Care Act is the same thing as Obamacare. This is a law, this is a little review for you here, passed in 2010. Most of the provisions of the Affordable Care Act became in effect in 2014. It created these healthcare exchanges which were intended to reduce the uninsured rate and make healthcare affordable for everybody. In Wisconsin did not take the Medicaid expansion, but we did end up expanding Medicaid to cover everybody at 100% of the poverty level and below, and everybody above that level was then eligible for what they called subsidies for their premiums. So in essence, we did reduce our uninsured rate by kind of a hybrid version of Medicaid expansion, different from what other states did. So those people between 100% and 40% or 400% of the federal poverty level were able to get subsidies to help them afford their health care. The things that helped to pay for the Affordable Care Act were these employer mandates. So if you had 50 or more employees, you had to pay a tax if you didn't cover your employees. The individual mandate, you had a penalty if you didn't buy insurance, and then there were lots of taxes built into the law for medical device manufacturers and other medical providers within healthcare had to pay taxes, and it all helped to pay for the Affordable Care Act. And then the impact, 24 million more people had health insurance by 2016. Goals of the Affordable Care Act, I think there was consensus before it passed that everybody needed more access to health care, that our costs were rising, people unhappy with their premiums going up. It was trying to bend the cost curve, but also to keep employers in the game, fix things in the individual market, ensure affordability, improve access to long-term supports. A lot of people don't know, Wisconsin actually did take advantage of one of the long-term services and supports options called the 1915I, which actually expanded self-directed personal care statewide. So we did take some of the advantages of the Affordable Care Act, even though we didn't technically expand Medicaid.
Oh, sorry. I'm fixing your camera.
All right. So the way things were before the Affordable Care Act, people with disabilities didn't fare very well. You could get denied coverage for having a disability or other medical condition, pre-existing condition, high premiums for people with high medical costs, denial of certain medications, benefits and treatments, annual lifetime caps. Many people with disabilities were unable to obtain health insurance and certainly unable to afford it. And people with disabilities prevented from working because they would lose Medicaid and then they weren't able to get health care in the private market. I was just recently talking to a dad from Southeast Wisconsin who talked about how he shared his Affordable Care Act story with me, that he actually got let go from his job because his employer did not want his son, who had really high medical needs, to be in their group employer insurance. And so even though he had never had a poor performance review, actually ended up being let go from his job and then was not able to get insurance then because of his son's pre-existing condition. So now, under the Affordable Care Act, he and his wife were able to be in the exchanges. So it's something that was very meaningful for him in order to have health care for his family. So it really made a difference. So benefits of the Affordable Care Act to people with disabilities. Can't be denied your coverage or lose your coverage because you have a disability. You can't be charged high premiums because of your health status. No annual lifetime caps. A very, very popular provision of the Affordable Care Act is that kids can stay on their parents' insurance till age 26. Has anybody taken advantage of that or know somebody who has? So, yeah, it's a big deal. Essential health benefits. I'll talk a little bit more about that. That was a very huge benefit to people with disabilities, and then a cap on families' out-of-pocket annual medical expenses. Okay, so essential health benefits. There was this thing established called the benchmark plan, which basically said all plans in a state have to meet what is the standard benchmark, and the benchmark has to include essential health benefits. The big thing for people with disabilities in this, and all of these are important, obviously, to people with disabilities, but something new was this reference to habilitative services and devices. So people are generally familiar with rehabilitative services, those therapies that help you regain a skill or recover from an injury, something like that. But for people with disabilities, generally habilitative are things that help you sustain your skills. So oftentimes for parents of children with disabilities, those physical therapies, occupational therapies maybe that you need regularly to support you with stretching and your tone, improving your tone, or sensory sorts of issues that people with disabilities have. A lot of that therapy is habilitative therapy. And so for the first time in the Affordable Care Act, we had a definition of habilitative services and an expectation that our benchmark plans had to actually include it, and that they had to be provided at the same level as rehabilitative services. So that was a huge benefit for people with disabilities in the Affordable Care Act. One other really important thing was that state mandates were grandfathered in. So in Wisconsin, we have several insurance mandates. One has to do with autism therapies provided in private insurance, so that became part of our benchmark plan, as did coverage of hearing aids and other supports for deaf and hard of hearing children. So because those were parts of Wisconsin's insurance mandates, they became part of Wisconsin's benchmark plan. So those were all very good things that had to be provided in the insurance exchange market for people with disabilities and all people. So how many people with disabilities benefit from the Affordable Care Act? This is national information, but there are a lot of people who wouldn't be in traditional Medicaid programs that were able to benefit from the Affordable Care Act. So you had people in Medicare in the waiting period, people who were not accessing Medicaid through their SSI, so they weren't quite, maybe they were waiting to qualify for SSI through their disability. Low-wage workers, there are a lot of direct care providers for people with disabilities that don't have employer health insurance, but were finally able to get affordable health insurance in the exchanges. And then dependents under age 26 that didn't have access to insurance other than through their parents. So, where do things stand? Let me check my watch here so I'm staying on time. A budget resolution passed the House and Senate. That was last month. And when I say a budget resolution, it's a specific tool that Congress can use to fast track elements that have a fiscal component. So they don't have to go through the typical process. So it says in the Senate, they only need a majority of votes. There's no, what's the filibuster opportunity. All they need is a majority of votes, which if they have a party line vote, it will be easy for them to move this through. So it's what they call a fast track process. This budget resolution directed committees in the House and Senate to write legislation that would achieve $1 billion in savings. So we'll talk a little bit later about how what they want to do with the Affordable Care Act repeals many of the taxes that pay for it, but then that means they have to find the $1 billion somewhere else. The House has proposed per capita caps to pay for the repeal. That was that bill that leaked on Friday. So that's what Lynn will be talking about. Biggest dangers of the Affordable Care Act repeal for people with disabilities, of course, that loss of the pre-existing condition protection, return of high-cost premiums, denials of medications, benefits, treatments, return to the caps, loss and erosion of the essential health benefits, and then that minimal coverage is just not adequate for most people who are trying to manage their condition. So you can see this is all very political. I mentioned that the governors are now in Washington negotiating with President Trump. This is actually a good thing because the states that have expanded Medicaid, so you see here, the expansion states, so all the colored states are states that technically took that full Medicaid expansion, so they got a 90% match from the federal government. So then we'll talk about Medicaid is a state-federal partnership. The state puts in a certain amount of money, the federal government puts in a match to that. In those expansion states, the match was 90% federal money. So that's a lot of money that all of those colored states have coming in from the federal government to pay for the expansion that they did in Medicaid. So they have a lot to lose if this is changed in some big way. And so that makes it a very political situation. In fact, in some ways, a very nonpartisan situation because there's agreements that they don't want to destabilize their healthcare market by pulling back that federal investment. All right, so this bill that came out on Friday, it repeals those taxes. So the medical device tax and the other taxes that really paid for the expansion, it takes away those individual mandates. So it doesn't require people to have health insurance anymore. And part of the reason why there was the individual mandate was to make sure that there were enough healthy people in the insurance market to kind of even out the cost for the sicker people who were going to be more motivated to get health insurance. Well, now that individual market is going to go away, so who do you think is going to stay in the insurance exchanges? It's going to be people who cost a lot more. So then what does that mean to the rest of everybody else's premiums? So that's a problem that people knew already existed with the exchanges, was that there were too many sick people, but now without the individual mandate, that particular problem is going to get even worse. In the bill on Friday, it eliminates these essential health benefits. It basically says, states, you can figure out what you think are essential health benefits. So if habilitative services are costly in states, you can bet there's going to be a reduction in what that looks like if there's no federal requirement. It creates the per capita caps for various subpopulations. Lynn will get into the details of that. Health savings accounts. It increases the amount that people can contribute to their health savings accounts beyond what they currently can contribute. It creates state innovation grants to create high-risk pools. So that's how states generally used to deal with people who couldn't get insurance in the private insurance market, but they really needed insurance for cancer or other very expensive needs. So Wisconsin had what has been touted in Washington as a model for this high-risk insurance program. It was called HRSP. Is anybody familiar with HRSP and how it used to work? So it ran from 1979 to 2014. It had 21,000 people in it, so it was the second largest in the country, but it had a lot of problems. So the guy from the Office of the Commissioner of Insurance in Wisconsin actually went to Washington and testified about how great Wisconsin's high-risk pool program was. And a lot of people say that that's not really how it worked out for most people. It still left more than 500,000 Wisconsin residents uninsured. It had a 6-month waiting period for pre-existing conditions, a $2 million lifetime cap, which you can imagine some people actually reach. It lost $6.9 million in 2011, so it wasn't even really paying for itself. It had a $2,500 deductible plan. It was at a $2,500 deductible plan, cost $354 a month for a 35-year-old woman and $847 a month for a 60-year-old man. So, I mean, this is what we might be going back to, and I think those waiting periods for coverage and the costs are a real concern for people who would eventually be pushed into that market if they couldn't get it on the exchange. So advocacy objectives, I mean, kind of where we need to go with the Affordable Care Act. It's going to be hard to stop the repeal because, like I started out, there are a lot of people who ran for election saying this was their goal. This is why they got elected, was repeal Obamacare. But we need to influence how it's replaced, how it's paid for, to make sure it doesn't harm people, and to educate policymakers about the Affordable Care Act benefits, and that the repeal is currently being funded by cuts to Medicaid. So if you read a lot of newspaper articles about this, you'll hear a lot of the politics about the repeal, but very little information that describes the types of Medicaid-funded programs in Wisconsin that are actually being proposed to be cut in order to pay for the repeal of Obamacare. So we need to try to get promises from our Wisconsin congressional delegation to retain pre-existing condition protection, to prohibit insurance companies from charging these high premiums, to retain the lifetime coverage caps, or the prohibition of lifetime coverage caps, and to retain the essential health benefits. So we're going to talk about our action plan and how we can work on that together after Lynn talks about per capita caps and block grants.
Yep. Just so you know, we have 14 participants on Skype or the phone. And this is what it's looking good. This looks like it's
Okay, so before we move on, I just want to point out, if you meet with a member of Congress or their staff, and you come in and say, I'm really, really concerned about the Affordable Care Act, and they say, well, look, let me just tell you right off the bat, I've already publicly said I'm in support of repeal. So I'm going to vote for repeal. So that doesn't mean your conversation is over. That's when you move on to the bottom of that slide, which is, okay, if you're going to repeal it, can we talk about what you're going to replace it with? And can we talk about how important it is that those 4 bullets on the bottom are there? And that's where the education comes in. That's where people with disabilities, family members, advocates have to point out how absolutely devastating it would be if an insurance company can deny you coverage because you have epilepsy or autism or Down syndrome or any of the disabilities of people that we're concerned about. That's going back to the dark ages before Obamacare. We never should let our country go back to that. And secondly, you know, if you can say, oh, well, you have a disability, you're going to be really expensive. So we'll be charging you a premium and your family that's 5 times as high as what we're charging most people. Well, that's devastating too. And lifetime caps. You know, when you hear a lifetime cap, you know, of $1 million, you think, well, that's a lot of money. Well, guess what? You go in the hospital 15 times a year, It's amazing how fast you can spend $1 million. So don't be, when somebody says, well, I'm gonna vote for repeal, we're gonna have something new. Okay, fine, let's talk about what something new is gonna be. And how important it is for people with disabilities that the something new has certain features. Okay, so now moving on. Quick overview of Medicaid. Just want to remind you guys what a big deal Medicaid is in our country. 81 million recipients. 1 in 4 people rely on Medicaid. And then if you thought, well, how many people live in a family where somebody relies on Medicaid? Well, it's probably up to like 1 in 3, 1 in 2. It's amazing. Growth in spending has been about 7% a year over the last 10 years. And you know what? Almost all of that growth is because more people are eligible. The average spending per person has stayed pretty level since the 1980s. The thing that's making it grow is like more people need it. More people are, being diagnosed with autism. More people are living longer and spending their savings, and then they become Medicaid eligible. So that's not a really outrageous number when you think about the demographics of our country. Projected spending over the next 10 years, if we kept our system the way it is now, would be about 6.4%. So that's the number that Republicans hate. They don't want 6.4% spending. They want 1 or 2% spending. So they're prepared to do whatever it takes to stop that trend that we've had the last 10 years and keep spending increases down, even though we know the demographics of the Medicaid population are going to keep going up. And of course, there's a deal between the state and the feds. The deal is the feds say, you got to provide certain services. Those are not optional, they're required. If you provide those services, then we will pay 60% in Wisconsin of the cost of those. And if you want to add some other services, if you want to go onto that optional list, which Wisconsin has, and we include almost all the optional services, the feds say, fair enough, we'll pay 60 cents on the dollar for all those optionals too. So that's the deal we've had for a really long time. And that's the deal that Congress is talking about blowing up. Okay, so Wisconsin system, 1.2 million Medicaid recipients. So Wisconsin, unlike the country that's 1 in 4, Wisconsin's 1 in 5. Well, that's still a really big portion of our state. As I said, you can see in the parentheses there, a bunch of the so-called optional services that we've had so long in Wisconsin, we don't think of them as optional anymore. How can you think of personal care as an optional service in Wisconsin now, where tens of thousands of people rely on it? So then, I won't dwell on this, but I thought I'd just give you guys a little glimpse of a couple counties. I picked Milwaukee, of course, for tonight. Yeah, go ahead.
Okay.
Those aren't all the programs, but those are just a few numbers for some of the key programs that, could be useful for you as talking points if you're talking to Sensenbrenner, Glenmore, whoever. Next slide is a sample of a smaller, actually, I'm sorry, the first one was Wisconsin, right?
Yeah, this is Wisconsin.
Okay, so those are the Wisconsin numbers. Almost 800,000 people in Badger Care Plus, 44,000 in family care, 91,000 in senior care, 13,000 in IRIS, 28,000 using the Medicaid purchase plan. And those are big numbers. Okay, then go on to Milwaukee. Then the last of the three is Eau Claire. I just want to give you a sample of a smaller county. Eau Claire has about 100,000 population. You can see, what that looks like in a smaller county.
I just have a quick question. What's the institutions category?
People who are in institutions and Medicaid's paying for them. So that could be people in nursing homes who spent all their money and now they're on Medicaid. So that'd be some elderly people. It would include some people with disabilities in private institutions, and of course it would include the state developmental disability centers. So that 251 probably includes some people living at Central Wisconsin Center or Southern Wisconsin Center. If their county of origin was Eau Claire County, they'd show up on this chart.
What
other thing to point out, with the baby boomer population getting older, that's gonna expand.
Well, it already has.
Yeah, if you.
Already has. When I talked about that 7% over the last 10 years, we're already seeing the effect of the baby boomers in that. But you're right, it'll just accentuate it.
Sorry,
Yeah,
one more
Melissa.
question. Where do kids using like Katie Beckett entering Medicaid?
Show me the one you think
the waiver.
They'll be in EBD. They be in the EBD population.
The last one, elderly disabled coverage. Yeah, that's the Medicaid card, right, Lisa?
Yeah, that's Medicaid card, so Katie Beckett's a waiver into the Medicaid card. I think there's a total of 6,000 kids in Katie Beckett statewide, and that's a really good point, because that's one of the things when Lynn said personal care is something we need to protect, that we don't want to go back to not having it. We have one of the largest Katie Beckett enrollments in the country.
Go ahead, practice.
Yeah. So, moving on to Medicaid block grants. Republicans have been talking about this for years and years. It's just that Obama in the White House for 8 years, he wasn't going to sign those into law. So they talk about it, they want to do it, but they haven't had the power yet to do it. Well, now they're feeling like they can finally do it. And, you know, as Lisa mentioned, that...
Can you mute your phone? Who's playing the piano?
10 years. That's what, well, no, actually, I'm sorry, this is something different. Last year, the House Republicans had a budget proposal for block grants. So that's not the one that's on the table now, but it's interesting to look at it because that is something that House Republicans wanted, and a lot of those members are still there. That proposal, if enacted, would have reduced federal funding to the states by 33% over the next 10 years. So that gives you a little glimpse. And when they talk about block grants, they're talking about that kind of a level of a cut. We've heard the President, Speaker Ryan, and the new DHS Secretary all saying, block grants, that's the way to go, that's what we're going to do. Interestingly, Governor Walker's position has evolved. In 2011, in a New York Times guest editorial, he said, block grants are the best option for Medicaid because Medicaid is facing a midlife crisis, and that's the only way Medicaid can survive. Okay, that was 2011. Last week, he said to the Washington Post, you can't cut Medicaid. There's just no way around it. You could even have something short of block grants as long as it didn't set states up for failure. So remember, Scott Walker is now the head of the Republican Governors Association. So I think what that means is he's hearing from other governors. This isn't just about Wisconsin. He's hearing from other governors, including some governors, Republican governors who did expand Medicaid, who are saying, wait a minute, we're concerned. So he's thinking, he's got to think what's good for all 33 of those states that have Republican governors. Which also means he's got influence too, because as the head of the Republican Governors Association, if he was to express concerns to Paul Ryan, to the president, to others, that could help us. So we're mostly talking about influencing Congress tonight, but the Long-Term Care Coalition's already sent a letter to the governor, and we are going to obviously try to convince him that this isn't such a good thing. Okay, so block grants, 2 versions. The first one would basically say, hey, whatever you got in 2017 for federal funding, that's what you're going to get for the next 5 or 10 years. Most people don't think they'll do anything that grim because that would mean 0% increase in federal funding. They want to get that 7% down to something lower. Most people don't think they'd actually be able to do 0 because Republican governors would say, wait a minute, we can't live with that. So it's more likely, if there is a block grant, it's more likely option 2, which is allow federal funding to increase at a predetermined rate. So if the predictions are that it would grow with the current system at 6.4%, well, let's pick another number, like maybe 2%, maybe 3%. Or another thing they could do is say, well, why don't we just tie it to inflation? Well, the thing about inflation overall in our economy, it's much lower than healthcare inflation. So that's a clever trick. Because oil prices have been down, inflation has been more like 1.5%. But healthcare inflation has been right up there around 7% or more in some states. So, but they wouldn't tie it to that because they want it to be lower than 7%. So option 2, you should mark that on your notes. that's the one, like, if you're talking to staff or a member of Congress and they're talking about block grants, they're probably talking about option 2. Now, just recently, and Lisa was in DC a couple weeks ago, and she emailed some of us and said, hey, Republican staffers on the Hill are really talking about per capita caps now. That seems like the thing that they're more likely to do. And per capita caps, from the point of view of governors, including Republican governors, that looks a little more appealing than a block grant because, as you were saying, Tiffany, as the number of baby boomers goes up and the number of eligible people goes up, you get more money for each additional eligible person. Under a block grant, you don't. The block grant says, we don't care. You can have a natural disaster and 10,000 more people lose their homes and become Medicaid eligible. It's your problem. You got your block grant, live with it. Per capita caps means we're going to put a cap on how much each enrollee can get on average. And if there's more enrollees, you get more money. So if you look at this slide, it would implement a limit on average federal Medicaid spending. It would not limit spending on any specific employee. So in a way, it's a little bit like family care, where there's the managed care organization gets a rate, but that rate will end up paying for some people who are a lot cheaper than that and some people who are more expensive. The same thing with per capita caps. They'd basically be saying, we're going to split up your Medicaid population into a number of subgroups. And the House bill that Lisa referred to has one list of subgroups, but other people have talked about other lists of subgroups, and that actually may change. That may be part of the debate. But for example, you could have all children with disabilities, say up to age 18, well, that's one group. And you could have, all elders over 65 on Medicaid, that's another group. You could have, the Badger care type population, childless adults, low income, that could be another group. And then what they do is they would look at your actual spending for each of those populations now, and they would say, okay, that's your starting place. So from then on, we're going to limit how much of an increase you can get on average per person for each of those populations. And that's the way they would go at it. Lisa just showed me today this thing that came out of the National Governors Association. Interestingly, what they're saying is, we think states ought to have a choice. It's like, choose this deep hole or this deep hole that you want to jump into. Block grants or per capita caps. But if that's true, then we obviously have to understand what both of those are. And of course, what we want to do is at least make one of those choices attractive enough that Wisconsin won't get hurt really bad by it. And of course, later on, when it comes to the governor and the legislature to pick one of those, then we're going to be trying to influence which one they pick based on how we think it'll affect the people we represent. But that's one of the reasons Lisa and I felt we had to talk about per capita caps, because we could get either one or a choice of both. So you can see what they could do. They could create one cap for all Medicaid recipients. Now that we've seen the House bill that has multiple groups, that seems kind of unlikely. It's also really a weird thing to do, to basically say, people that live in Central Center and people in Badger Care, we're going to create one per capita cap for all of them. It just doesn't seem like it would work. The other thing is, Congress could leave certain groups out of the caps. There's a really good paper from the Government Accountability Office on this, where they explain a lot of different ways that the Congress could set this up. And one of the things they said is, you could have certain populations, like let's say the nursing home population, where you don't put a cap on them, because if you did, you might see an erosion of quality. You might see more and more people dying in nursing homes. That would be a national scandal. So maybe we don't want to go there. So there'll probably be some debates, and you can imagine the nursing home industry coming in and arguing, you should exclude our population. And different people will probably debate that. Last bullet, you could have certain federal accountability measures, but it probably wouldn't be the ones we have now. Because part of the deal with the governors is to say, okay, you're going to get less money, but there'll be less rules to worry about. Well, that might sound good to governors, it doesn't sound good to us, because those are the rules that protect people with severe disabilities. Okay, so potential impacts on people. Talk about the first. You could cap enrollment. You could say, look, that's all the people we can handle in IRIS. Can't take anybody new. You could freeze enrollment for a while. You could have time-limited enrollment, where certain programs you could say, well, yeah, you can enroll, but you can only stay in 3 years. Well, for people with lifelong disabilities, time-limited enrollment doesn't sound like a very good idea. Of course, you can easily predict return to wait lists. I mean, just in the last year or so, the state took the final step on to end adult waiting lists and have the last remaining counties come into a situation where there wouldn't be any waiting anymore. Well, we could undo that 25 years of work. The governor just announced he wants to end waiting lists for kids. That would be great, but maybe we won't see that, if this happens instead. You can have a divided entitlement, which is what we used to have, where you've got an absolute right to a nursing home, but you don't have an absolute right to services in your home. So you have wait list for in-home, but no wait list for nursing home. You can see some of the other things that you could do. Eliminating Medicaid school services. Already people have said, oh, why, there's already school personnel. Like, why do you need extra services? Why do you need Medicaid? Schools get money anyway. Isn't that double dipping? I mean, it's been sort of a controversial thing anyway. I think somebody told me recently that's $40 million in Wisconsin. Okay, so impacts on programs. Maybe you could eliminate all the existing waivers. If you take the rules off, you're not necessarily requiring states to apply for individual waivers. It's like, here's your block grant, here's your money, you spend it the way you want. Yeah.
I just wanted to ask, what about the assisted living places where I live actually? I live in an apartment, which talks about assisted living.
Yeah, assisted living, I mean, what they could do is cut the rates. I mean, they probably wouldn't eliminate it because they're not going to want to make a lot of people homeless. They might just say to those agencies, you're not going to be able to get much of an increase anymore, so forget about that. And that might happen.
I also want to ask this, all this information that you're giving us now, does it also impact the DHHS in Milwaukee and the ADRC?
Yep, every agency, every county that relies on Medicaid could be affected. And then ADRCs are funded by Medicaid, so yeah, they could be affected for sure. So you could cut the rates for family care, you could cut the overall state budget for IRIS, cut provider rates. I mean, obviously, if you say to the family care managed care organizations, you're going to have less money, they got to turn around and pay less to their providers. Because they're not in this to make deficits, so they're going to have to figure out how they can make ends meet. If they did eliminate some optional services, there's agencies that exist solely to provide certain so-called optional services. Well, those agencies would go under. Those jobs would be lost. So we came up with this litmus test. There's so many different issues you could raise about block grants per capita cats. We wanted to sort of boil it down. So if you're talking to a legislator or a congressman or their staff, we feel that you could boil it down to a pretty short list of questions. Is this going to increase the tax burden on our taxpayers? So if the cost of Medicaid keeps going up, but the feds are saying our share is not going to go up, then what's going to happen? The Wisconsin taxpayers are going to have to make up the difference. And it's going to get worse every year because the gap between the cost and the federal revenue is going to get bigger and bigger. Will any current recipients lose their eligibility? If the state has more flexibility to define eligibility, are they going to kick some people off? Will we start having waiting lists again? I mean, there was a bipartisan consensus in our legislature to eliminate waiting lists. That's gone back for several governors, some Republicans, some Democrats. Are we going to lose that now? And will any services that people currently receive be eliminated? And lastly, will it lead to rationing? And there's a bunch of different forms of rationing. They're all listed there. So our goal is we don't want to give up on the idea that we could get some members to vote no. And it's really important to remember, not every member of Congress in Wisconsin has come out publicly and said where they stand on this. And they're already hearing it at the town hall meetings. And if they can hear more of it from us, we might be able to get some of them on the fence. And that's what happened with 2.0. Some people, there were members who were saying, oh, I'm not so sure. I got a lot of questions. That's a really good response. We love that. That's much better than saying, too late, Julie. I've already told the newspapers I'm voting for repeal. I mean, hard to get them to pull that back. But if they say, I'm still learning, I'm listening, I got a lot of questions, I got concerns, great, great. Because we can give you a lot more questions to struggle with. And we can just keep you getting concerned and more concerned. And eventually, some of those I'm not so sure can turn into no's. But for those we can't get to know, we need to educate them on exactly how this is going to affect people with disabilities and see if we can get them to vote for something that will do the least amount of damage. So I'm running out of time here, but just that next slide. Those are 5 things that we've heard people say in defense of block grants and per capita caps in the green there. And our response to that is listed. Hopefully it's pretty self-explanatory. If not, we can answer questions about that. Then lastly, before I turn it over to Lisa, we had a brainstorming about this in Survival Coalition recently. And when we were talking about how to get the message across,
you want me to change
that? Yeah, next slide. We felt like it was really important to make it real and make it personal. So instead of saying, I'm really concerned about that Medicaid's going to get cut, that's going to hurt a lot of people, that's a bit vague. It's much more specific to say, my son relies on school services, and if he loses those, he may not be able to stay in school. We're going to lose our respite care. That's going to really mess up our family. I could end up in a nursing home. I'll lose my job coach, and then I'd probably lose my job. I won't be able to live in my apartment anymore if I don't have people who are Medicaid funded coming in to support me there. If I don't get adequate health care, I'm going to end up in the hospital. I already know what that was like. I've been there before. I'll lose the support I need to self-direct my services. If you take away my IRIS consultant and you just say IRIS is, here's some money on the stump, good luck with that, that's probably not going to work for a lot of us. So what we're saying is, don't talk about Medicaid in some vague general way. Talk about it in a really personal way. Talk about how you rely on it, what that program is. Remember, a lot of elected officials don't know that IRIS is a Medicaid program. They don't know these programs we rely on are actually Medicaid. So you got to really make it personal. And then I heard somebody talk about this today. With 1 in 5 people in Wisconsin relying on Medicaid, you can really think about how much our entire communities, like in that picture, 20% of those people rely on Medicaid. You take away Medicaid, what happens to those people and what happens to our communities? You know, there'll be a domino effect in terms of people losing their homes, people getting sick, people using the emergency room, people losing their jobs, kids not being able to stay in school because of their lack of school services. I mean, there'll be a whole bunch of ways that our communities will be affected. And then a few more talking points that you could choose from if you want to pick some of those up. We do think this is going to pass the buck to the states. We do think states are going to have to come up with the extra dough. So let me just stop there. And before we move on to advocacy strategy, anybody have any questions on any of this stuff we've talked about? The Obamacare, Medicaid block grants, per capita caps. Sally.
I think the flexibility is because I've gone to see some people, and that's always kind of that sticking point. And so I guess maybe just a little bit more about how to answer that. In that I understand about the waivers. I think we say,
you know, we use the flexibility that's available right now in Medicaid to create the IRIS program. That's an extremely flexible program. It's the biggest, most successful self-direction Medicaid waiver program in the United States. That's an example of how Wisconsin has definitely been able to use flexibility. I think you could say the Children's Long-Term Support Waiver. I I mean, there's an incredible variety of stuff that families can get. It seems to me like there's a lot of flexibility in that waiver right now. So yeah, I think there again, if you could answer it in real terms, which is, well, the Medicaid program I use, Medicaid program my family has, it has flexibility enough for us to do, you know, whatever. I mean, I think answering that way if you can. Yeah, Julie.
One of the things, I mean, you have to tell me if this is true or not, about how the money comes from, comes to the states.
You mean now or in
No, with a block grant or per capita, is it gonna come as like, you know, because there are no requirements then, it's gonna be, you know, because it really, the flexibility they're talking about is like the state's flexibility, you know, the governor's flexibility or the legislature's. So right now, when there's a waiver being put together, you know, because the waivers have to be renewed, what is it, every 5 to 7 years?
5 years, I think.
5 years? Okay, so there's a stable plan for 5 years. And when they rewrite, you know, they renew their waiver and they have to rewrite it, there is all kinds of procedure about, you know, public hearings and things like that, where there's time for people to comment. And, you know, it has to go to CMS, the federal government, to make sure that it complies and everything. Now, with the new funding, so if it comes in per capita money or block grants, that's going to be simply budget money, right? So everything, all the changes to anything in Medicaid don't require public hearings or anything. It's just going to be a budget.
They could still leave certain requirements if they want to. And it's so early in the debate now, it's really hard to know what they'll leave in. Now, interestingly, think about something like the Americans with Disabilities Act. I mean, that is federal law. So I'm not sure they can just say, oh, here's a bunch of federal money, and oh, guess what? You can ignore the ADA. You can ignore the integration mandate. You can ignore the Olmstead decision. I don't know if they can do that without repealing the ADA, which I think would be a very unpopular thing to do. So my assumption is they still will be somewhat subject to those kind of constraints, which helps us. You know, elderly people don't have anything quite like the ADA. For them, it's more like anything goes.
Well, but my thing is that if this is something, you know, the money will come every year, or, you know, the state does a biennial, you know, budget, you know, so we do it every 2 years, does that mean that, well, we all know how hard it is when they make a small change to long-term care or something like that.
You're talking about how hard it is to get CMS to approve it.
No, well, how hard it is to implement it.
Right.
And, you know, we have a five-year stability period. You know, we know that when a waiver is accepted, that people with disabilities in the state that use that particular program have 5 years of a relatively stable situation. Right. Is this, my concern is that it's going to be able to be changed with a budget.
Yeah, so imagine if they do block grants and Wisconsin chooses block grants.
Yeah.
At the beginning, it's going to be complete chaos.
Chaos, yeah.
Because there'll be a debate. Do we even need separate programs like family care, partnership, IRIS, CLTS? Like, why do we need those? Doesn't that just mean like extra state staff? Like, can't we just consolidate that all and make it into one simple generic program? You know, one size fits all. And so there'll be a debate about whether or not we want to keep these individual programs. And then once they settle that, then from then on, I think it's pretty much states get to do what they want to do. Now, one thing to think about is if per capita caps mean the feds will give Wisconsin a certain amount of money for each person in each subgroup, you would think the feds would still have a concern about how eligibility is determined, right? Because if you let everybody in, you can get a lot of federal money. Let's make everybody Medicaid eligible in Wisconsin. You know, then we can get money for 5 million people. Well, I can't imagine the feds are going to let us do that. So they're probably going to have some kind of federal eligibility criteria, but, you know, I'm just guessing. So other questions? Yeah, Neely.
Yeah, my question is, what is the maximum limit of money that individuals with disabilities can make?
Oh, well, right now, you know, that's part of the Medicaid system in terms of, and SSI, you know, there's rules that determine if you make more than a certain amount, then your SSI check will go down a little bit. If you make even more than that, your SSI check will go down even more, and you keep making more money, at some point you lose your SSI check. But we have ways in Wisconsin that you can earn more money and still stay in the Medicaid program. Now, we don't know if those rules will change or not. I mean, I would think that the state of Wisconsin would want to keep people in Medicaid because then they can get federal match. If they change the rules so everybody loses their Medicaid, then those people show up to the emergency room with no forward card, and then somebody's got to pay for them. So I don't think they want to kick everybody off Medicaid. Okay, a couple more questions before we move on. Yeah.
Maybe I will, but who's going to be eligibility is something that it comes federal or gonna let the states, and how is this that we are hearing about childless adults and all that stuff is beginning to give an idea about where, so who determines eligibility?
Well, like I was just saying, I think the feds are gonna still have to insist on certain things there because they don't want us to make everybody Medicaid eligible in Wisconsin. So they're gonna probably have to specify certain things. But just like everything else in Medicaid, we all assume that states are gonna have more flexibility in the future than they've had in the past. Yeah, Melissa.
What are they considered to be inflexible about the current way Medicaid is run?
Well, the stuff that Julie Burch was talking about, like, well, why do we have to apply for these waivers? And why do we have to get renewal every 5 years? Why don't you just leave us alone and give us the money? Just let us do whatever we want. So you could, you know, if you didn't have to apply for waivers and you weren't subject to federal rules, I suppose you would have more flexibility. But what we're trying to say is, in the current system, you already have quite a bit.
And in Medicaid, there are mandatory services. So there's a set of mandatory services. I can't remember how many there are. And I think in flexibility, there would be, they could choose off the menu of which ones they wanted to provide and probably keep their list really short to the ones that cost them less.
Yeah, sure. Charlie, go ahead.
I mean, one other argument about the flexibility piece, though, is to say that we all like flexibility, right? We want to get the car that's the color we want the leather seats or not the leather seats, or we want whatever. But if you can't fund the engine running, it doesn't really matter what the other options are. So it's just one other way to bring it back to the original argument that, yes, that is a nice thing, but at what cost? You know, and if the cost is that we can't then provide adequate health insurance for the people that are trying to get the basic benefits, then it may not be worth it just for that bit of flexibility, which it doesn't seem like we need in this state anyway, because we have the flexibility we need.
Right.
So you can kind of wrap it together.
Right, and also, we don't really want the flexibility to be able to put people in seclusion and restraints 24 hours a day.
Right.
Right, I mean, some of that lack of flexibility is in defense of people's rights. We don't necessarily want to give that away. Okay, in the back.
What was the impact of all of this on Medicare and Social Security? It kind of references it in that one slide.
Yeah, the coalition that we're part of has some aging advocates in it, and they've actually been working on a paper to explain some of the spillover. But you know, what they reminded us of is that there are people under 65 on Medicare. So there are people with disabilities who are under 65 who are on Medicare who could be affected if they start messing with Medicare. But the other thing is that, you know, a lot of people on Medicare have Medicare supplemental insurance, you know, so-called Medigap insurance. And it's not really clear how this is going to affect that either. So that's fuzzy. Right now, we're not hearing any rumors that Congress is looking at a major overhaul of Medicare. The president gave a speech yesterday, or he was at a news conference where he reiterated his defense of Medicare and Social Security, but ominously, he didn't mention Medicaid in that press conference. So some people are thinking he said his promise a lot of times in the campaign about Medicare and Social Security, don't worry, don't worry, don't worry, I won't mess with it. He didn't say as much about Medicaid. And the fact that the House came out with this draft bill that Lisa was talking about that would clearly put Medicaid into per capita caps, that suggests that there's some kind of a communication between the White House and the House Republicans saying, take a run at Medicaid, you know, we'd be willing to consider that. But, you know, don't mess with Social Security and Medicare, at least not right now. So, Lisa, you wanna?
Sure.
We're gonna move on to talking about advocacy strategy right now.
Yes, fair. Somehow I'll get them up after you're done.
We'll just take like a couple minutes.
Okay, so want to make sure everybody has the handouts from the back. The My Save Medicaid Action Plan, the People First Wisconsin Cares About Medicaid, Keep Our Care at Home, questions for Wisconsin policymakers, and then the Wisconsin Congressional Delegation. Do y'all have those four? Okay, excellent. Do people at home, did they get attachments?
Oh, no, but they could. I can send them tomorrow.
Okay, great. So in terms of advocacy strategy, everything is happening at the federal level right now, because as I mentioned in the earlier slide, if this change happens at the federal level, everything starts to unravel at the state level. So our job is to convince the Wisconsin Congressional Delegation that this is bad for our state. I think that's really where we need to focus, not kind of at the larger talking points, but what it means for our programs and supports here in Wisconsin. And then to the degree that we can, I think we'll start paying attention to other states that are influential. And if we have, you know, relationships, friends, relatives that live in those other states, that's another way that we can influence the process if we either get our people on board or we're not making progress. So steady drumbeat in Congress. I called Mark Pocan's office today, and I think that anybody can, you know, make a call a week, a couple calls a week, checking in, maybe take a new question off of the questions list and ask that question, or if your member is already siding on with you, ask them to ask their other Wisconsin Congressional Delegation those questions on your behalf. We need a focused message, so we want to be using our key talking points that Lynn mentioned in the PowerPoint. And then we want to ask members and their staff self-educating questions. So questions that you have about the programs and supports that you receive or that your loved one receives, and whether or not those are going to be able to be continued. How the program works for you today, what kinds of changes are going to happen. So give your congressional member or staff some homework on your behalf. And I think any one of the many questions on the Keep Our Care at Home handout are questions that you can use to go back and ask congressional staff and congressional members. We really are hoping to leave here tonight with some district-specific strategies so that you can be working in teams and that you're not kind of going solo, that you're working with other people in your community. So that's what our goal is. All right, so yeah, coordinated efforts in every district. We want calls, emails, letters to every member, week in, week out until they vote. So I think I read today that I think Speaker Ryan wants a vote within the middle of March. So this is moving very, very quickly. So very important that we're gathered tonight, but wish we had all these chairs filled. Mm-hmm. So it makes our work a little bit, greater to have some coffees with your neighbors, your other partners, and other friends get connected after today. We do have a list of people who have volunteered to be captains in every one of those congressional districts. If you volunteered, I know there are some captains in the room. Who's volunteered to be captains? I saw Melissa, your name's on the list. Yeah, Maria's on the list, Melissa's on the list, Julie, Nancy, who else? Amelia, I think you were in the group. There are captains in every district. Lynn, do you want to name those people off that are listed as captains?
Yeah, let's see. For Ryan, we've got Courtney Waller listed here. So we had one other Ryan constituent here tonight. Who is that?
Okay. Mary.
Mary Sorority.
Mary, would you be willing to be a co-captain, team up with Anybody else on this?
Yeah, I actually meant to follow up on that. And I was thinking, did I sign up for that? I couldn't remember. So yeah, if I have, it'd be great to know somebody else in my area anyway, so.
Yeah, Courtney would be a good person to team up with. So then, Gwen Moore, we have 10 people here tonight, and we already have 3 co-captains, Kevin Fetch, Maria, and Nancy, who are both here. So do you think we should recruit another one, or do you think 3 is enough?
We can, when we gather in groups, that they can decide if they want to add another co-captain.
Okay, then Sensenbrenner, we got Julie Burrish, Patrick Young, and Sally Flashberger. I don't know, you guys, when you get together, you can talk about whether you need to add another person. One of the things I think about, well, Gwen Moore is probably going to vote against any of these changes in Medicaid.
Right.
But we still want to educate her because we want to make sure that she's got really good examples of why this is bad.
Right.
But Sensenbrenner, I think, is actually one of the Republicans who we might have a chance at.
Annie has public town hall meetings.
Yeah, and
his wife also has a disability.
Right, and I think he has other family members with disabilities. And when they did the amendments to the ADA, he was considered to be a friend of people with disabilities. I mean, I feel like if we've got any chance, he's one of the people we may have a chance with. So it seems like it'd be really good to get a lot of activity in his district.
He's still got many town halls. He has one this weekend. He's coming back again.
One thing I was going to say about Gwen Moore is, and this is true for me in Pocan's district and other people like Melissa who have Pocan. That's an area where you can focus more on media and community outreach. So you can still continue to educate your member and ask them to influence other members of the delegation, but then you might shift more of your energy into media and some other community strategies.
Does that include TOSA?
Yes.
Does he include the Children's Hospital? And the Medical Center?
Yeah, I think so. It's a very weird kind of, it can go pretty far into Milwaukee County.
Yeah, when you guys sit down, you can talk about a strategy to deal with them. And who's the rest of them?
And then the only other, there's one person here from Pocan's district. Is that Melissa?
Well, and then you and I.
Yeah, Melissa's already signed up as a co-captain.
And we do have people on from up north. I mean, I can see some of the phone numbers, so I don't know if there's people you want to mention so they know.
Do we know who's online, who has RSVP that's on the phone?
Well, I can see some 715 phone numbers, but it's just because they must be on the phone.
Maybe Jason, Andres, I think.
Yeah.
Maybe George.
Yeah, I can see George, Abby, Anna, Jason, Cooper, Joanne, must be,
so could we?
But then there's some phone numbers because they must be just on the phone.
So,
sorry,
Sally,
we can't hear you.
Could we give them your email address?
Yeah.
So they can let you know if they want to be co-captains?
Everybody who's on the phone or on the video, you can respond to, there were several emails, but the Skype email, or I can send an email to the list tomorrow. But just respond if you want to be a captain, and then we'll set you up.
All right, so coordinated efforts. We want number one thing we want is a group of people to be meeting with that representative or senator. Another thing that folks who are in the more friendly districts on this issue could do a focus on the Senator Johnson. You know what I mean? So think about where else you can have influence outside of your district if you don't have the big heavy lift in some of the districts that we really haven't locked in yet. And then media, super, super important on this. Congress people read the op-eds, editorials. I'm pretty convinced that the reason that bill leaked on Friday was kind of a barometer. What are people going to say about this? How popular or unpopular is this idea? That's what happens in politics. So now it's kind of bubbling up. So what does Wisconsin say? I think that's probably why Governor Walker is kind of being a little bit more tepid. In that article in the Milwaukee Journal-Sentinel on Sunday, he didn't seem like a cheerleader for Medicaid block grants, and he was just shortly after the election. So I think that has to do with what public opinion sounds like. So part of the story is a story in this room, you know, people with disabilities and their family members, but it's also about the economy. And so we'll talk a little bit about how that's part of your strategy too, is thinking about the hospitals, thinking about providers and their jobs, all the people who are employed. If 1 in 5 people are in Medicaid programming in Wisconsin, there's a heck of a lot of people whose jobs are connected with delivering Medicaid services. So I know, for instance, I was saying the other day, I have a chapter of the ARC in Fond du Lac, and they deliver a lot of services through Family Care and Iris. 85% of their revenue is Medicaid, and they have a lot of jobs there. They are $1 million, $1 million industry in the city of Fond du Lac. That's a lot of jobs. It's a big part of their local economy. So it's something to think about, to broaden your message. It is about quality of life for people with disabilities and family members, but it's also about local economy. So we're gonna map out a strategy tonight that gets you into that meeting where you're gonna use these talking points, but also use the talking points in the media. And we're gonna use a variety of different types of strategies to do that. Nancy?
I know I've been trying to copy some of the things I send out to like Senator Johnson or whatever. I've been trying to copy in like Alberta Darling and Representative Knodel as well. Just saying, look, I'm really worried about this. I wanted to show you what I've sent on to your colleagues at the federal level.
Right.
Because I feel like they should take some responsibility. Like we should be making sure that I see them as they need to work together. We need to figure this out. I mean,
right.
I think that's a really good idea. The other thing is you're educating them too. Right. The thing is, of course we know Congress gets the first kick at the can, but while we're influencing Congress, we can be educating our state legislators, because if Congress does do whatever they're going to do, we're going to be coming back to these state legislators saying, okay, now they're giving us a block grant, so you have a lot of flexibility. We don't want you to use that to hurt people with disabilities. And you've already built up a little bit of a trail of information, so you're not starting from scratch then. I think it's a good plan.
I think of it as a trickle up strategy too, because I think that, Lynn mentioned that our Success as Advocates last year around Family Care Iris 2.0, that was a proposal that came from the governor's office, but really it was derailed because there were legislators who were hearing from their constituents and said, I don't want to be taking a vote on this. I'm convinced this is going to hurt my constituents. So they then convinced the governor to withdraw the proposal. And the same thing could happen here if there's enough pressure from local legislators who frankly are far more familiar with Medicaid funded supports. I mean, they still have to do a lot of educating, but when you say the words Family Care and Iris to your state representative, they generally know what that is. But I was in a meeting with Paul Ryan, and I'm not sure how familiar he is with how Family Care and Iris work in Wisconsin and how much Medicaid funding that is. So I think the trickle up idea of state legislators who are in the same party as your congressional member, who probably have a relationship with that person, is going to definitely influence their opinion. Julie?
When Nancy and I, our little group, went to see Ron Johnson's staffers, that was one of the things we suggested, that we would put together a group, that we could get together a group of local Wisconsin legislators who, based on what happened with 2.0, heard loud and clear from their constituents how important, the long-term care benefits, which are Medicare funded or Medicaid funded. And something that was in the paper today, that 2/3 of people on Medicaid in Wisconsin are impoverished elderly and people with disabilities. So it's 2/3 of Medicaid. So I think that's another number that 2/3 of the people on Medicaid will have.
Right, it's not these the childless, able-bodied people that they're putting work requirements in.
And I think that's really important, is that, that when you talk to legislators, you make that very, very clear. This isn't about health insurance, this is about care for the vulnerable people. But I think that's too, that we should encourage our local legislators to work up too, because they heard so much. I don't think they,
Neely, you had a question?
Can you repeat what you just said?
What about, can we also bring up the issues when we do the Disability Advocacy Day?
Definitely, that's perfect. So who's going to Disability Advocacy Day? All right, does everybody know what that is? March 20, March 21st?
20th and 21st.
21st is the day in the Capitol, so that's where your meetings are scheduled with your state legislator. So definitely something just a time to educate them about the Medicaid supports and programs that you might use and how important they are to you, and how you hope they'll be a voice for you in Washington. Good point, Ely. So personal commitment, we're going to take some time to work on your Save Medicaid action plan, and wanting you to leave tonight committed to something, and because we don't have a full room, to maybe move outside of here tomorrow and try to get some other names on this Medicaid action plan with you. First goal is we would really love for you to agree to go to a meeting with some other people in this room or other people in your congressional district to have that meeting with a member of Congress. Continue to write members of Congress and Senator Baldwin and Senator Johnson. I know Julie just mentioned the meeting with Senator Johnson's staff, and there was one other partner from our current partners group that also had a meeting with Senator Johnson's staff, and the reports out of both of those meetings were that they were continuing to educate themselves. It definitely was not a yay, block grants, can't wait for them to come to Wisconsin. It was definitely, the report was, I'm still in learning mode, which, as Lynn said, is really good. So the more you continue the drumbeat of all of these questions and concerns, I think you keep them in that status.
Lisa, I just want to add, a group meeting with a congressional staffer is easy. Because you go into that meeting with 4 or 5 or 6 other people, and you've agreed in advance, like, okay, I'm gonna talk for 1 minute or 2 minutes about my son and about how Medicaid affects our family, and then I have to stop because there's 5 or 6 other people. So, you're not gonna have to carry the ball all by yourself in this. You're gonna have your friends with you, and if there's questions, good chance one of you will be able to answer it. If not, you can do what we always said in partners, which is, I'll get back to you with the answer to that question. So, don't be scared off of doing a group meeting with a congressional staffer. It's not hard.
And I think it just keeps that drumbeat. Did you have a question?
I was just going to comment that meetings with congressional staffers are just as effective as when you meet with a legislator.
Absolutely. You're going to inform and mobilize other people, letters to the editor, work in the media. We'll talk a little bit about that. So just a few of the challenges. I've been following some of the training and support that's happening at the national level, and it's hard to engage other people on this issue if they're not facing healthcare crisis. They haven't experienced it themselves. And so it seems abstract, it doesn't seem relevant, and a lot of these issues have been so politicized that people just they don't want to have anything to do with it. So the barrier is, getting other people to care, and I think that's how we do that with our stories. So I think it's important, if you either tonight, if you work in a group, or you go back home and just invite some people for coffee who you think might want to care with you. So do a Facebook group or something and say, can we just meet for coffee on Saturday morning and talk about this? To find out what some of the most compelling stories are within your group. Okay, so when you go into a meeting with a congressional member or a senator or staff, it's not like necessarily everybody tells their story. Everybody might have a different role, but you want to leave them with the most compelling story. We probably do have compelling stories in this room where people with very compelling stories. So that story is going to help you get the attention of media, get the attention of that staff person, get attention in your community. If we want to have the most impact, we're going to think about all 3 different types of audiences. So that congressional member, of course, the policymaker, your state legislator, but of course the media, huge reach, and then general public, your friends, neighbors, your doctor, all of those people that might have interest in this issue. And then you want to make sure that each message has a call to action step for the audience to take. So the policymaker, you want that person to vote against, to not support this policy. You want your media to share your stories and get attention to the issue, and you want your neighbor to better understand the issue and to engage on the topic. So here's just an example of how even in just a tweet, you can really get a very compelling story across. So think about all the different social media avenues that we have today to get people's attention. You can tweet at policymakers, you can post on Facebook pages, you can put comments on articles on newspaper websites, and even in just a very simple few characters, you can really get a pretty compelling message across. So Sally, I think we have a little time. Can you put those memes up there?
Yes, I'm gonna try.
All right. So over the weekend, the Long-Term Care Coalition worked with some partners. I think you'll see some familiar faces in this to put together what we call some memes, and we'll be sharing these. So memes are just an image that has a very compelling text on it, and you can share them on social media, on Facebook or Twitter. And so
Nice work, Sally.
So we're using this fill in the blank, a threat to Medicaid is a threat to, and then trying to tell the story of what Medicaid looks like in Wisconsin.
So that's just a clue for you guys. That could be your message. A threat to Medicaid is a threat to my daughter and her chance to have the life that she wants to have.
You need some music.
That's a good way to start a sentence, and you guys can finish that sentence.
I had an idea about music, because we had to buy that song for our More Than a Diagnosis.
Yeah.
We own it.
Oh, we do?
Let's do it.
Okay. Do you want me to run
Yeah,
through
let's
this?
run it as a slideshow or whatever. You'll see all the.
Oh, yeah, I can run it as a, wait. I'll just do it.
Just for folks who are in Skype.
That's me.
We're putting up photos, and Sally will share this with you. So these are a threat to Medicaid is a threat to my
So
son's
the text on the
dream of
bottom's
getting
cut
a
off,
job.
Sally, I don't know.
Oh, it is?
Yeah.
Oh.
Well, it must just be where the projector is.
Oh, that one's okay.
A threat to Medicaid is a threat to my ability to live in the community.
That's weird, I don't know why it's showing that.
A threat to Medicaid is a threat to my employment support, transportation, ability to volunteer. A threat to Medicaid is a threat to my future goal of becoming independent. That's Miss Abby, who I think is on the phone.
She is, she's on, I think.
A threat to Medicaid is a threat to my son's future. That's Anna Moffat's son, and I
Oh,
think she's
he's
on
cute.
the line. A threat to Medicaid is a threat to, and this is a wordle that shows every single one of
good.
Wisconsin's Medicaid-funded programs. So you're in Bertha 3, Katie Beckett, Medicaid card, SSI managed care, children's long-term supports, mental health programs like comprehensive community services, family care, PACE, Badger Care, Wisconsin chronic disease. All of those are funded through Medicaid. A threat to Medicaid is a threat to my daily personal care, preventing a devastating fall in the shower. That's Jason Endress. I think he's on the phone or something.
So?
A threat to Medicaid is a threat to Iris. A threat to Medicaid is a threat to family care. A threat to Medicaid is a threat to our Aging and Disability Resource Centers, our ADRCs. A threat to Medicaid is a threat to over 1 million Wisconsinites.
Let me just say something about ADRCs. About 30 to 40% of the revenue of ADRCs is money they get above and beyond their standard ADRC grant because they can bill Medicaid for doing certain things. The ADRC folks are really worried that a block grant or per capita cap may mean that they won't be able to bill for any of their work anymore. So that will result in a 30 or 40% cut for an ADRC where 40% of their money comes from billing Medicaid. So that wouldn't be so obvious to people until you talk to the ADRC folks and you realize where their money comes from.
So, I'm sorry to interrupt, but do you know how much longer they need? Because we have this one at 7 p.m.
Oh, you do?
Oh, you do? Oh, I'm sorry, no one told us that. I asked for it till 8.
How big is your group?
It's for Elena. It's for Elena.
Oh, I'm so sorry. Okay, yeah, I asked for the room till 8.
We mostly have small group stuff left. If we took tables all the way back and you stayed.
Or we could go out in the, we could go out in the hallway, it's private. 'Cause it's
Yeah, there's space out there.
We
That's
could go
right.
out there.
Okay. So.
Yeah,
so we're gonna basically break into groups by congressional district,
Yeah.
right?
So
maybe
does anybody have any questions that need to be asked right now? What, Maria?
Well, I want to, it's not like a general comment.
Okay.
And in it, really bad.
Yeah, I booked it.
Okay, we'll get to that in a moment. Did you have a question?
Just observation.
Okay. All right, should we move out and go to our?
Yes,
counters?
if people want to take the food out there too, I guess I
And what
gotta.
are the directions to the people on the phone or Skype?
Oh, thank you very much. I will send you the materials and follow up with you in the next day or so.
And if you want to be a captain, make sure you are emailing back to Sally.
Right.
So we can get you connected to other people that want to participate in your congressional district. Thank you.
Thank you, thank you.
So just head out there, find a table, and we'll join you in a minute.
Okay.
But like Sally said, if you guys can grab a
Grab
bowl or
something
something
and
with you,
here we
that'll
go.
help.
Stop recording.